Okay, let's dive right into this. Welcome to today's Explainer, where we're going to tackle one of the most common, high-stakes presentations that you face on the front lines: acute chest pain. For a really long time, emergency and primary care physicians have been kind of trapped in this outdated, hyper-defensive paradigm when evaluating these patients. So today, we're going to look at exactly how to replace that stressful, defensive mindset with the modernized AHA and ACC clinical pathways. Our main goal here is to help you safely navigate patient presentations, optimize your dispositions, and really finally break free from that traditional never-miss culture.
Here is the structured journey we are taking today. 1. Rethinking acute chest pain. 2. Initial evaluation pathway. 3. Applying HART and EDAX. 4. Managing low-risk patients. 5. Disposition and share decisions. And finally, 6. Summary and key messages. Section 1. Rethinking acute chest pain. The burden of over-testing.
Let's start things off by just taking a second to look at the sheer overwhelming volume we're dealing with amidst the absolute chaos of a busy shift. Nearly 7 million. That is the number of emergency department visits for chest pain annually in the United States alone. It's actually the second most common reason for emergency care, period. That is a massive, staggering influx of patients requiring rapid triage, evaluation, and really tough decision-making by docs every single year.
But here is where the systemic problem really lies. Despite those 7 million visits, only 13% of them actually result in an acute coronary syndrome, or ACS, diagnosis. Think about that for a second. This massive contrast between the sheer volume of presentations and the incredibly low rate of actual, true emergencies highlights a serious issue. We are dramatically over-admitting and over-testing our patients.
So how do we fix this? Well, we have to start with how we even talk about it. The latest AHA/ACC guidelines explicitly tell us we need to strike the word atypical from our vocabulary entirely. Why? Because patients, and let's be honest, sometimes even clinicians, interpret atypical as meaning benign. Instead, we really need to shift our lexicon firmly to non-cardiac, if we just don't suspect heart disease, or possible cardiac. I know it sounds like a small terminology shift, but it forces absolute diagnostic clarity right from the very start.
Moving on to Section 2. Initial evaluation pathway. The critical first 10 minutes.
Okay, so what exactly should happen when that patient first hits the doors of the ED or your clinic? Here is your rapid mental algorithm. The bedrock of the modern initial evaluation pathway is a strict, non-negotiable 10-minute triad. First up, get a 12-lead ECG within 10 minutes of arrival. Second, utilize high-sensitivity troponin testing. This is absolutely the preferred biomarker to quickly confirm or exclude myocardial injury. And third, you have to systematically rule out those immediate non-ischemic life threats, specifically thoracic aortic dissection and pulmonary embolism.
Let's dig just a bit deeper into ruling out those specific life threats. For suspected thoracic aortic dissection, you don't want to just rely on a gut feeling here. You need highly targeted testing. You should actively be using the Aortic Dissection Detection Risk Score, or ADDRS. If a patient has an ADDRS greater than 1, or maybe a score of 1 combined with a D-dimer over 500 nanograms per milliliter, that prompts an immediate ECG-gated CTA. Boom, no questions asked. Also, if you have it available, a prompt transthoracic echocardiogram is highly recommended, so you can rapidly evaluate cardiac function and spot things like pericardial effusions or signs of PE.
Now, when evaluating physical presentation clues, ischemic signs on the ECG are pretty obvious, right? ST elevation, a new left bundle branch block. But remember your anginal equivalents: dyspnea, nausea, and fatigue. These are especially common in women, the elderly, and diabetic patients. On the flip side, sharp pain with inspiration, pain that totally changes with position, or fleeting pain lasting only a few seconds, that strongly points toward non-cardiac causes. And here is a literally crucial reminder to update your old paradigms. Relief of pain with nitroglycerin is not an accurate diagnostic criterion for cardiac ischemia. Scratch that old habit completely. Do not use it to rule in ACS.
Section 3. Applying HART and ADAX. Evidence-based risk stratification.
Now, what's really interesting about this slide is how we transition from our initial clinical impressions to cold, hard, objective data. You should absolutely be using a standardized clinical decision pathway. Two of the absolute most validated out there are the HART score and the EDAX score. Looking at a recent comparative study in a North Indian setting that evaluated patients with undifferentiated chest pain, both tools proved highly effective at predicting major adverse cardiac events, or MACE. Using a heart score cutoff greater than 5 yielded a 73% sensitivity, while an EDAX score greater than 16 showed a 76.2% sensitivity. The big takeaway for us? Both are incredibly robust, independent predictors that you can confidently rely on.
Visually, the ROC curve from this study really just reassures us of the predictive value and the safety of these scores. You'll see the blue line represents the heart score, and the green line is the EDAX score. They provide a lightning-fast, incredibly reliable predictor right there at the bedside, giving you real confidence without requiring complex computer calculations or formulas.
Section 4. Managing low-risk patients. Breaking the never-miss habit.
This all builds into arguably the single most crucial behavioral shift we need to talk about today. We have to acknowledge the elephant in the room. Historically, even with great clinical and lab data, about 1.5% of ACS cases are missed in the ED. Now that 1.5% miss rate absolutely terrifies clinicians, and understandably so. Nobody wants to face litigation or, worse, patient harm. It has driven this deeply entrenched never-miss culture. But this defensive habit, the practice of just admitting every possible chest pain for observation and advanced testing, it actually harms patients with false positives and completely unnecessary radiation, and it's costing the healthcare system over $7 billion annually.
So, the crucial turning point is this explicit, powerful directive straight from the updated AHA/ACC guidelines. Listen to this. Low-risk patients with chest pain do not need urgent diagnostic testing to rule out coronary artery disease. Let that sink in. If you stratify a patient as low risk using the heart or EDAX pathways we literally just discussed, you are empowered to stop the workup. You do not need to admit them for a stress test just to soothe your own anxiety.
Section 5. Disposition in shared decisions. Now, knowing you can discharge a low-risk patient is one thing, but how do you practically execute a safe disposition while keeping the patient totally comfortable and confident in your care? The answer is shared decision-making. Just look at the results of the Chest Pain Choice trial. They utilized a really simple web-based decision aid with low-risk ED patients. By visually sharing the calculated risk with the patient, literally showing them their actual pretest probability of having a heart attack, patient knowledge increased, and it safely resulted in an absolute 15% decrease in observation unit admissions for cardiac testing. And honestly, the best part? There was zero increase in major adverse cardiac events. Sharing the data protects both the patient and the physician. It is a total win-win. But what about the patients who aren't low risk? Well, the guidelines have clarified this disposition pathway beautifully as well. For intermediate-risk patients with no known coronary artery disease, coronary computed tomography angiography, or CCTA, is now your absolute default advanced imaging choice. It decreases the time to diagnosis by 50% compared to traditional nuclear stress testing. If they already have known CAD, you want to maximize their blood pressure and cholesterol management first. And obviously, your high-risk patients, they should bypass all of this and go straight to referral for invasive coronary angiography.
Finally, Section 6. Summary and key messages.
We've definitely covered a lot of ground today, shifting away from those old defensive habits to modern, truly data-driven practices. So here are your definitive clinical pathway takeaways. 1. Mandate that 10-minute ECG and absolutely rely on high-sensitivity troponins. 2. Eliminate the term atypical chest pain from your charts and your conversations. It's either non-cardiac or possible cardiac. 3. Stop guessing and objectively calculate a heart or EDAX score to stratify MACE risk. 4. Break the never-miss habit by using shared decision-making aids to confidently and safely discharge your low-risk patients. And 5. Prioritize CCTA to save crucial time for your intermediate risk evaluations.
I really want to leave you with this final thought to ponder. Do your current ED protocols align with these evidence-based pathways, or is your department still trapped in the defensive, never miss an ACS mindset? It's time to champion these structured, modern pathways in your own clinical settings to improve patient care, reduce unnecessary testing, and totally optimize your department's flow. Thanks for joining me on this explainer. Keep learning, keep pushing the standard of care forward, and I'll catch you on the next one.